Thanks, Bob, for that really kind introduction. It's really a pleasure to be here with you today. I love UW. I've been up here a number of times, and it's good to be back. I love Seattle. It's really a pleasure for me to be with you and talk about one of my professional interests, interstitial lung disease. It's not astrophotography or metal music, but this will have to do for today. So let's see if I can get this to work. First things first. This is the first test. Oh, there we go. I have one disclosure. It has nothing to do with the topic of this presentation. So I'm going to start out today sharing a case, and what I hope to do today in all of this talk is really to provide some perspective on interstitial lung disease, where we are as a field right now, and where I think we're going and where pathologists fit into that. I'm not going to teach you how to do interstitial lung disease today. I don't think that's possible in 45 minutes. But maybe this will help you think about ILD in a little bit different way than maybe you've thought of it before, and to illustrate some of the current challenges in our field and kick us off. I'll share with you this case. So this is a case that I received in consultation now maybe a year and a half ago. This patient was a 52-year-old woman. She had some nonspecific things in her clinical history. She had hypothyroidism, some joint pain, and I was told she had had ILD for about 8 years. She also had a light history of smoking as a teenager. She was a school teacher. She didn't have any obvious inhalational exposures, no mold in her home, no birds, pet birds, etc. And her high-resolution CT scan showed findings that were said to be indeterminate for UIP, usual interstitial pneumonia radiologic pattern. She did have an elevated ANA titer, 1 to 320, but otherwise negative serologies. And the clinicians weren't sure what was really going on in her lungs, so they ended up doing a surgical lung biopsy. And this is what came across my desk. So I'll ask you to look at this case and think what you might do with this case. So I think here at low magnification, we can clearly see this is abnormal lung tissue. There's probably something fibrotic going on. It's quite heterogeneous. There's quite a few lymphoid aggregates here. We come in a little bit closer. You can see numerous lymphoid aggregates in the fibrotic process, some with germinal centers, but you can also see these paler areas of active fibroblastic proliferation at the periphery of the fibrosis at the interface with the adjacent uninvolved lung, so-called fibroblast foci. Coming in on another area, you can see there's a pretty diffuse cellular interstitial infiltrate, kind of a diffuse mild lymphoid interstitial infiltrate. Other areas, again, prominent germinal centers, and then fibroblast foci, again, is sort of a classic appearance of a fibroblast focus at the interface between destroyed fibrotic lung and adjacent uninvolved lung. One more image here of prominent lymphoid hyperplasia within this fibrotic process. So this is your case on your desk. What would you call this by current criteria? Is this a definite UIP pattern, usual interstitial pneumonia, like we teach in training? Is this a probable UIP pattern? Is it indeterminate based on current criteria? Would any of you call this NSIP or airway-centered fibrosing interstitial pneumonia? Or maybe this is just unclassifiable. There are some features here that one might make a case for UIP with. It's heterogeneous, it has fibroblast foci, but there's some features that would be unusual for UIP pattern as it's currently defined. It's got prominent lymphoid hyperplasia, so maybe you might call this indeterminate for UIP. There maybe are others in the audience who'd say, this is just unclassifiable. I don't know how to classify this thing. And those, I think both of those answers would be reasonable with current criteria. The problem with this is it doesn't help the pulmonologist who's trying to figure out what to do with the patient, who might think, oh, my pathologist is useless. I got this surgical lung biopsy to clarify the problem. Do I give the patient steroids? Do I start antifibrotics? Do I just send the patient to a transplant surgeon? What do I do next? And my pathologist has not helped the situation. So unfortunately, these days, this is not an uncommon problem where the pathology doesn't really fit for something specifically, and we end up with this, what I think of as sort of a wastebasket or garbage diagnosis that's not clinically useful. So today I want to talk about problems and kind of where we are in the ILD world. The first thing I think we all know if we are doing lung pathology is the guidelines are confusing. There is histologic overlap among many of the diseases that cause fibrosis in the lungs. There are no defined diagnostic thresholds currently. How much lymphoid hyperplasia is too much lymphoid hyperplasia? When do we call it UIP? When do we not call it UIP? There is no gold standard in this field. Right now, multidisciplinary discussion is said to be the best. Maybe it's a silver standard, and it's what we currently use to classify disease. But multidisciplinary discussion is not perfect. And as anybody knows who sat in on an MDD discussion, how do those end up being resolved? Well, they're usually resolved by the most opinionated person in the room. That's sort of the big dog phenomenon, right? You have a big dog pulmonologist or a big dog radiologist or a big dog pathologist, whoever happens to be the one with the strongest opinion, sort of has the end word on the case, and then that person is treated accordingly. The last problem is everything is idiopathic until it is not. Of course, the whole purpose in having a diagnostic workup, including a lung biopsy and everything else we do clinically, is to not diagnose idiopathic disease. It's to not diagnose idiopathic disease. So we have these idiopathic disorders, idiopathic pulmonary fibrosis, idiopathic NSIP, cryptogenic organizing pneumonia. And they get diagnosed a lot, but it's sort of a cop-out, if you will, to end up with an idiopathic diagnosis. Sometimes it's the only diagnosis that we can give at the end of the day, but that's not the purpose of the whole venture. The purpose is to avoid an idiopathic diagnosis, but that's a problem for pathologists. And how do we get away from an idiopathic diagnosis and into a diagnosis that has more meaning or more relevance with biology? So what's new for pathologists, and how does it relate to these problems? This is going to be what I cover here today, just to offer some food for thought. I'm going to start out talking about where we are with practice guidelines and some of the problems with practice guidelines and limitations and how I think we ought to be thinking of these guidelines. And then I'm going to shift into discussing the problem of fewer biopsies, the disappearing lung biopsy and why. And then one of the shifts in the field, a shift between phenotype and etiology and how diseases are classified and treated. And then I'll end the talk today with just a little bit of discussion about what I think are some opportunities for us as pathologists in this shifting field. So, practice guidelines. Problem number one. Guidelines are great because they can take a messy field and create order out of it and provide a common language for us to be able to use so that we know that we're all talking about the same thing. And in ILD, the idiopathic pulmonary fibrosis guidelines first came out in 2011. There were several updates since then, including one in 2022, and these have really important people's names on these guidelines. So, for example, there's the first author of this is someone you probably all know here in your own institution. Dr. Ragu is internationally regarded one of the best pulmonologists in the world for ILD. And these guidelines have a whole host of other luminaries, global luminaries in the field. And as part of these guidelines, specific criteria were established for diagnosing a UIP pattern, including histologic features that can be used to help the pathologist in arriving at the correct diagnosis. And if we look at these a little bit more closely, these guidelines also offered us not only criteria and terminology, but also grades of certainty. So either a case could be classified as definite UIP, or maybe if not all the features were present, we could call it probable UIP or indeterminate, or maybe suggesting an alternative diagnosis, reflecting the diagnostic uncertainties that happen in real practice. And furthermore, these diagnostic guidelines were helpful because it offered us a way to integrate that pathology information into the greater clinical picture, to be able to decide, does the patient have idiopathic pulmonary fibrosis or some other problem? And what you're supposed to do with these guidelines is take this matrix here and look at what the high-resolution CT scan shows, and then match it up with the histopathology, and then that would give you the magic answer, right? So if the high-resolution CT is probable UIP and the histopathology is definitely UIP, then that patient's going to get diagnosed with IPF. So this is actually, it's great from a practical standpoint. The problem is this also has some limitations, some other issues with it. And some of these issues have been compounded in more recent years by development of more guidelines. So hypersensitivity pneumonitis, fibrotic HP, is something that is always in the differential diagnosis when we look at advanced fibrotic lung disease. And distinguishing this from other disorders like IPF is important clinically. And this is the first time we had international consensus guidelines for the diagnosis of hypersensitivity pneumonitis. And like the IPF guidelines, these guidelines were devised with sort of a similar logic with categories of certainty, HP, probable HP, indeterminate for HP, with histologic features that were included to put it in one category or another. And then how to integrate this in with the clinical information. These guidelines also provided us with a matrix like this, where again, the imaging can be combined with whether or not the patient has a relevant exposure, and then combined with the histopathology to decide the level of confidence of a diagnosis of hypersensitivity pneumonitis or not. So this looks great from a conceptual standpoint. But what do you use as a pathologist? Which guideline supersedes the other guideline? And how do you bring these together? And to illustrate that, I'll just offer one quick example. So this is a case you might get across your desk if you're signing out lung pathology. Maybe this case is clinically suspicious for IPF, the high-resolution CT is indeterminate, and the patient ends up with a biopsy. And you get something like this. It's clearly fibrotic, it's heterogeneous, at low power. This is not a bad appearance for UIP pattern. And you look a little bit more closely, and there's fibroblast foci, everything seems to fit. And then you find a poorly formed granuloma, which you're not supposed to have. Or maybe you do, or maybe you don't. So the first pathologist looks at this case and says, well, the process has dense fibrosis with architectural distortion, maybe honeycombing. There's predominant subpleural and paraseptal distribution of the fibrosis. The process is patchy, it's heterogeneous, there's fibroblast foci, there's a single granuloma, but the patient has GERD and maybe is aspirating a little bit. I'm going to let that go. I'm going to sweep that under the rug because everything else here is perfect for UIP. I'm going to diagnose that as UIP. And then this ends up getting input into the schematic. The high-resolution CT was indeterminate, but the histopathology was UIP. That patient's going to get diagnosed with IPF. Pathologist number 2 gets the case and says, there's a bunch of features of UIP here, but there's also a granuloma. And I'm worried about that granuloma. That could be something else. That pathologist classifies this as indeterminate for UIP based on current criteria, which don't actually delineate how many granulomas are too many granulomas, or the characteristics of the granulomas, or all these other little more minor characteristics. How do you use those to refine your histologic diagnosis? And just says, well, this is indeterminate for UIP because there's a granuloma here. That person's going to get a diagnosis instead where indeterminate for UIP and indeterminate for UIP meet. That's clinically indeterminate for IPF, which is exactly where the patient was to begin with. The patient had a biopsy for indeterminate disease, and it's still indeterminate, which is not very helpful. This might make you as the pathologist feel a little bit like this. Remember, the pulmonologist is already thinking, my pathologist is useless. Now you're thinking, well, the guidelines are useless. How can I be a good pathologist when I don't have good guidelines to use? So then we get even more stuff in the literature, proliferation of things like this. A guideline for the guidelines. This actually came out in 2022. Guidelines for how to use the guidelines. and how to bring the guideline for fibrotic HP and the guideline for IPF together, and when to use one versus the other, and how to match all these things up, and recognizing, of course, there's a big gray area in the middle, and there's a spectrum that goes all the way from IPF on the left to fibrotic hypersensitivity on the right, and everything in between, which I guess is, again, great from a conceptual standpoint to help people to recognize what to do in more challenging cases. But sometimes this is hard to apply in real-life practice. One study I think is really interesting to consider is this that came out of Japan a couple of years ago, comparing guidelines to each other and the patient outcomes based on different guidelines. This study had 280 consecutive patients with chronic fibrotic ILD who had had biopsies, and these investigators applied both guidelines, the 2018 IPF diagnostic guidelines and the 2020 hypersensitivity pneumonitis diagnostic guidelines, and then compared the groups with these two different classifications. And this is what they ended up with. Of those 200 some odd patients, in the left column, the farthest left column here, you'll see the IPF guidelines. About half the patients, when you applied the IPF guidelines, met criteria for IPF. The other half were not IPF. But then when you classified them by 2020 HP guidelines, about 2/3 were felt to not be fibrotic HP. The other half were felt to be diagnostic of fibrotic HP. And you can see here, interestingly, when you cross these two categories together, 42 out of 200 and whatever patients met criteria for both diagnoses. So how is that possible that you can meet criteria for both diseases using these two guidelines? Take the HP guidelines and there they are. If you compare the clinical elements of fibrotic HP here versus IPF patients here in the green boxes that are shown now here, you can see there's actually at the bottom the histopathology, typical or probable HP. Most of the patients called HP meet those histopathologic guidelines, but check this out. 28% of patients in this study had probable HP on histopathology but would meet criteria for IPF, which means we really have a specificity problem in pathology. Well, does this even matter? I think it's a more important question to ask. If you take these patients and look at the survival, patients who met guidelines for IPF and then subgroup them into those who also met criteria for HP versus those who did not, there was no difference in transplantation-free survival. On the other hand, if you look at those patients who met criteria for fibrotic HP, and then ask yourself, how do the patients who also met criteria for IPF versus those who did not, how do those patients fare? And there actually was a significant difference in survival. So the patients who met criteria for IPF as well did worse. So bottom line is, if you meet guideline criteria for IPF, your course resembles IPF, regardless of whether or not you also meet criteria for HP. So just a few thoughts about guidelines. We have these guidelines for a reason. They provide common language. They provide a good starting point for thinking about these diseases, which is better than complete chaos. Remember, guidelines, however, are based heavily on expert opinion. Evidence is lacking for a lot of elements that are in the current guidelines. They create diagnostic complexity, as illustrated by some of these cases. How do you bring these guidelines together? Which ones do you use and how? They also may create a false sense of certainty about the diagnosis. If guidelines are met, does that patient have what you think they have or not? And remember, they are just guidelines. They do not replace clinical judgment. So clinical judgment, careful discussion among the people involved in the patient's care is always going to be better than just blindly following guidelines. Okay, I want to shift gears a little bit to the disappearing biopsies now. And those who sign out lung pathology, at least people who sign out a fair amount of ILD, will probably recognize that biopsies are disappearing. So I got interested in this question in our own practice because we felt like the biopsies were disappearing. And we did a retrospective look in our own practice locally in Arizona, looking at the number of biopsies and the distribution of diagnoses in patients before the adoption of the 2011 guidelines and then after. And this is data from that study we published a few years ago in Archives. 2 4-year periods, pre and post implementation of the IPAF guidelines, and then classified them based on the fibrosis that's present. And I won't bore you with all the details of this, but I think you can see really easily that after 2011 guidelines were established, the biopsies have dropped off considerably in sheer numbers. But not only have they dropped off, but I'll call your attention to the red and dark red bars there. Regardless of patient age, the number of cases of UIP or probable UIP based on current guideline criteria and classify them that way, they have also disappeared in real life practice for a variety of reasons. But what that means is those classic cases of UIP that we used to think about and sign out are infrequently encountered in clinical practice. And what are we left with? We're left with all the tricky cases that are hard to classify. So why are these biopsies decreasing? First of all, we know that surgical lung biopsy has significant morbidity and mortality associated with it. It's not an insignificant procedure. So if it can be avoided, it should be avoided. And we understand that better than we used to. Cryobiopsies have come onto the scene. I understand there's not really cryobiopsies performed here, but in a lot of institutions, those are now being done. And they do have acceptable accuracy for diagnosing UIP, at least in some series, and so may be used as a surrogate for surgical lung biopsy, so surgical lung biopsies may be disappearing for that reason. The IPF guidelines allow you to diagnose IPF without a biopsy in certain kinds of clinical settings. You don't need a biopsy anymore, whereas in the past that might have been necessary. There's a molecular classifier of UIP that's being used as a surrogate, which I'm going to get into in just a moment. And then a shifting focus from etiology to phenotype, and this introduction of a new clinical term, the progressive pulmonary fibrosis phenotype, which I'll also mention briefly. So I want to talk about a few of these. I'm not going to talk anymore about the risks of surgical lung biopsy, but just for those who don't know what a transbronchial cryobiopsy is, I'll just briefly share this with you. So as opposed to a transbronchial forceps biopsy where a bioptome is introduced through the working channel of a bronchoscope and then little pieces of lung tissue are taken from an endobronchial location, a transbronchial cryobiopsy has a cryoprobe introduced into the bronchoscope that has a special tip on the end of the probe, which can be made freezing cold when the operator turns it on, this metallic tip. And the operator puts it into the appropriate position down in the airway and then turns the cryoprobe on, and it will freeze the tissue into this little snowball with an enlarging piece of frozen tissue. It's like sticking your tongue to a flagpole in the middle of the winter, if anybody saw the Christmas Story movie for the holidays like I did. And the longer you hold your tongue stuck to the flagpole, the more your tongue freezes on the flagpole. It's the same idea. And then at a certain point in time, after it's been frozen long enough and the snowball is large enough, the operator will withdraw the bronchoscope out and tear that little piece of tissue out of the lung. And because it was not crushed with metal jaws of that forceps, but it's been frozen in situ, that tissue is perfectly preserved. Now, there's some risks to this, bleeding, et cetera, as you might imagine, but the histology that comes from these transbronchial cryobiopsies is actually quite nice. And how does cryobiopsy compare to surgical lung biopsy? That's one of the key questions, because if you can avoid a surgical lung biopsy and get the information you need just from a transbronchial cryobiopsy, maybe at less risk to the patient, then that's a good thing. So there are actually some studies now published looking at how well these compare to each other, how concordant they are, surgical lung biopsy compared to cryobiopsy from the same patient. And in fact, the data is still somewhat mixed. Data from the coldest study was positive, said they compare quite well to each other. Another negative study is here saying they don't really correlate very well. Another more recent comparison study was small, but had synchronous transbronchial forceps biopsies, cryobiopsies, and surgical lung biopsies from the same patient, and compared the histology and the multidisciplinary diagnosis to look at concordance between all of them. And you can see the data here on the right side. And just sort of scanning down these, you can see the forceps transbronchial biopsies. Not really surprising, they're not very useful. But when you compare the surgical lung biopsy to the transbronchial cryobiopsy, the concordance here, it's not perfect, but it's pretty decent. And that's been our experience as well. It seems to be quite operator dependent, and it's not perfect, but in some cases at least, you can make a pretty good diagnosis with a fair amount of confidence on transbronchial cryobiopsy as long as it's been performed well. One of the issues that explains the disappearance of biopsy in addition to cryobiopsy is the current guidelines that no longer require a tissue diagnosis to diagnose IPF. So if a patient comes into the clinic and is suspected of having IPF, and after a clinical workup, there's no obvious potential cause or associated condition, it's clinically idiopathic, that person gets a high-resolution CT scan, and a radiologist sees either UIP or a probable radiologic UIP pattern, that person's going to get diagnosed with IPF and will never have a biopsy done. So who gets biopsies now in 2023/4? It's these people who have indeterminate imaging findings, or maybe imaging suggesting some other problem, who then end up getting a transbronchial cryobiopsy or surgical lung biopsy, depending on your institution and your pulmonologist's preference. And remember, they are now going to be more likely to show an alternative diagnosis simply because we have an intrinsic bias to the process now. And those classic cases of UIP are not going to be biopsied. So remember, when you get a biopsy on your desk, those patients have a biopsy precisely because they don't fit well clinically for UIP, IPF. Therefore, the pretest probability for a non-UIP diagnosis is probably significantly higher than it ever used to be. And our data has at least supported that idea. So if you like grids like this better, remember UIP and probable UIP radiology is not even going to go to biopsy. And the pretest probability of seeing these histopathologies has decreased, UIP or probable UIP, because of that clinical guideline. Therefore, this is what we are left with as pathologists that come across our desk. Some of them are going to be indeterminate for UIP, kind of mixed patterns, sort of like UIP, not sure. And then there's going to be a bunch of other cases you're going to see that are going to have other things going on. I actually see classic UIP so infrequently even in our consult practice now, that when I get one, I go down the hall and I show it to my colleagues. Check it out, look what I got. I got a classic UIP. It's been 3 months since I've seen one. And we see probably a half dozen to dozen cases of ILD in our consultation practice every single day. So in my experience, and that may be referral bias, but in my experience, UIP has very much disappeared from clinical practice for the surgical pathologist, depending on where you're practicing, of course. So, do we even need a pathologist? This is a relevant question. Maybe molecular's better. So, it requires less tissue. Maybe it's more objective because it doesn't have human bias. Maybe it's more reproducible for the same reason. Maybe it's more sensitive, maybe it's more specific. It's not surprising that people might become interested in an alternative to pathology when we aren't able to provide a really definitive diagnosis. As those of you who do lung pathology know, a molecular test has come onto the market in the last few years, and in the spirit of full disclosure, I was part of the validation for this test. It's years ago, so I didn't provide it in my initial disclosure, but I was part of this process for development of this particular test that is now being used quite a bit in clinical practice, which promises to accurately detect a genomic pattern of UIP without histopathology. Sort of the bronchoscopist gets a piece of tissue from a transbronchial approach, sends it off to this lab, they grind it up, and you get this binary result back. It's either UIP or it's not UIP. And the company claims that you can confidently identify UIP in most cases compared to histopathology. Pretty good concordance, almost 80% of the time if it's histopathologically UIP, the test will detect that genomic signal of UIP, which is great. The problem is it has some Achilles heels that I think if you're doing this in your practice or your clinicians are interested in this test in practice, it's important as a pathologist to recognize what those Achilles heels are. So at least you can have a productive discussion and manage expectations of your clinicians. So I think one of the most important Achilles heels to recognize with this test is that it was never validated to discriminate etiologies. It was validated to detect a UIP pattern as a general pattern, but it was never detected to diagnose IPF and distinguish it from fibrotic HP or connective tissue disease-related fibrotic ILD. It was validated to detect UIP pattern only, even though I have seen it being used in that fashion by some people. The cases in the validation were classified by only 2 to 3 expert lung pathologists, which, even pulmonary pathologists can't agree upon how to classify these processes perfectly. What I might call UIP might be something that another expert pulmonary pathologist would never call UIP. So what kind of a gold standard is that? That is a limitation of this molecular assay. As I've already mentioned, it provides a binary result, UIP or non-UIP, which one might argue could be an oversimplification of biology. It still requires an invasive procedure. You can't acquire this information without an invasive procedure and a biopsy, yet it completely bypasses a pathologic evaluation. Or if a pathologic evaluation is performed, it's performed on other tissue samples, but not the one that's sent off to be subjected to molecular testing. So what are you missing from the sample that was never sent to pathology? You'll never know if you never look. And maybe it ignores potentially meaningful findings. Was there a lot of lymphoid hyperplasia in the sample? Were there granulomas in the sample? Were there other findings that might suggest what the underlying etiology was for the pulmonary fibrosis? You'll never know with this assay. It just simply comes back with a binary result, UIP or non-UIP. Should we use this molecular classifier in practice? I think this is something that's continued to be debated in the field. An interesting study published out of Europe last year looked at almost 200 patients with fibrotic ILD and looked at their progression-free survival based on what their genomic classifier, this test, showed. People who had a genomic UIP pattern or a genomic not UIP pattern. And you can see here there's no statistically significant difference in progression-free survival regardless of the result of this genomic classifier. So does it have any real value in clinical practice? There are certainly people who think that this provides at least some value. I don't know what's being done here at UW. In our practice at Mayo Clinic, we have not seen value in this at this point, and we don't use it. I know a number of people out in our community are using it as a surrogate for pathology to work up their patients. Time will tell how robust this test is and how much it can be relied upon, but I do think that it's important for pathologists who are involved in the care of these patients to just simply understand what the potential limitations are of the assay and ensure that their clinical colleagues are also aware of the limitations. So, coming back to this slide, why are surgical lung biopsies decreasing? It's a real simple answer. The value simply does not justify the risk anymore in many patients. So that's why they're going down. Phenotype versus etiology. This is another thing that's changing in the field. So how do you classify disease? It's helpful to think about this if you don't think about this very often. We can classify disease based upon the etiology of the disease, the underlying cause. There's a connective tissue disease, there's aspiration of food, there's an infection, there's an organic antigen that's patient's been sensitized to, whatever. Or we can classify disease based on the phenotype, the result in the patient. The patient's got acute lung injury, respiratory failure, chronic respiratory dysfunction with fibrosis, etc. And both things are important. The etiology is critical because that's how you target therapy, but the phenotype also can be important when deciding how to treat a patient. Remember, splitting diseases into smaller etiologic groups is essential for precision medicine. That's what we do. Become more and more precise about how we approach disease treatment. But lumping is also helpful with phenotypically similar diseases because it's practical and it unifies therapy. So there's always this thing in medicine between the lumpers and the splitters. Are you a lumper? Are you a splitter? When do you lump? When do you split? And in pulmonology, we have been splitting for a while, and there is a current shift towards a lumping mentality with a new disease term, the progressive pulmonary fibrosis phenotype. And it's been recognized that many of these disorders that are believed to probably be distinct from each other, like sarcoid, chronic fibrotic HP, connective tissue disease, drug-induced interstitial lung disease, all these different things, many of these patients will have a progressive phenotype where they continue to get more and more fibrosis, more and more respiratory dysfunction, and that maybe it's not so critical to subclassify them etiologically. Maybe it's more important simply to recognize the phenotype and try to treat the phenotype with anti-fibrotic therapy, and there's some data to support this treatment approach now. And really all of the fibrotic interstitial lung diseases, we know now that a subset of patients, sometimes more often, sometimes less often, depending on the specific disease type, but some proportion of patients in all of these categories will progress clinically, and that's represented here with the shaded proportions of each of these diseases. So maybe we can just lump them all together, or maybe it's a step in the wrong direction. So I'll offer you this just as something to think about. I think in pathology for many, many years in interstitial lung disease, we've been too focused on phenotype. We pay attention to patterns. That's what we do. We look for patterns pathologically. But as you get into this and practice this more often, you soon realize that UIP is not synonymous with a clinical pathologic diagnosis of IPF. Just like organizing pneumonia is not synonymous with clinically cryptogenic organizing pneumonia, idiopathic disease, nor is our friend diffuse alveolar damage the same thing as ARDS to the clinicians. The pattern of injury is not the same thing as the actual clinical entity. And yet we've been focused on diagnosing the patterns so much for so many years, maybe at the expense of diagnosing the etiology for so many years, and maybe we can improve how we approach these. So how do other specialties handle this issue? Well, you don't have to go far. If you sign out other areas of non-neoplastic lung pathology, you realize it's handled differently. And this is renal. I'm not a renal pathologist. I sign out renal transplant pathology, but not medical renal stuff. But the renal people know this, that their biopsy report should be etiology and pathogenesis driven by consensus. You're supposed to include in your report not just the pattern, FSGS or whatever. You're supposed to include information in your report about what the potential underlying cause is. Is it lupus? Is it some vasculitic process? Is it IgA nephropathy, etc.? You're also supposed to include scoring metrics, like basically staging. How bad is the disease? Is it early disease? Is it late stage disease? The liver people know this too. So this is a question for the trainees in the room. I certainly learned this in my residency. Hopefully Dr. Rashadi did too. How do you guarantee a phone call from a hepatologist? Guaranteed hepatologist call. As pathology, we don't like phone calls, right? We try to sign stuff out in a manner that avoids the phone call. We're introverted. Diagnose a liver biopsy as cirrhosis. You never just sign it out as cirrhosis, right? Why do you not sign it out as cirrhosis? Because it matters what causes cirrhosis, right? If you sign it out as cirrhosis, it's like showing up to a crime scene where it's filled with cops and investigators and saying to the folks who are there, guess what? A murder happened here. I can see evidence of a dead body. There's a chalk line. Well, ignoring the other important information. There's a baseball bat on the ground. There's booze on the fireplace mantle here. Maybe there's some other paraphernalia around. There are clues at the scene that suggest what caused the murder, right, or the death. So think about that, because different things cause cirrhosis, right? If you see features of steatohepatitis in the background, maybe that's because of that problem. Maybe it's a viral hepatitis leading to cirrhosis. Maybe it's chronic biliary disease, biliary obstruction. Maybe it's cardiac disease with evidence of venous outflow obstruction. We see these additional secondary findings in the biopsy that suggest what the real underlying problem is. And that stuff is of interest to the clinicians who are trying to treat the patient. So why are we okay with UIP in the lung? It's cirrhosis of the lung, if you want to think of it that way. But there's additional features in many of these biopsies that can at least point to a potential etiology. And really, it's the etiology that, at least historically, has been important in how we treat these patients. Even in an era where we're shifting more and more towards a general phenotype, progressive phenotype, I think there's still information here that's of value. And there are at least some people in the field who have proposed a more etiology-based classification of diffuse lung diseases. Lung diseases like those that are systemic inflammatory disorders, or vasculopathies, or exposure-related disorders like hypersensitivity pneumonitis, or radiation, or drug-induced lung disease, or those diseases that are intrinsic to the lung parenchyma, et cetera, surfactant deficiency disorders. There's a whole host of things that I think might be better thought of in these kinds of etiologic categories, because that tells you more about the underlying biology that's causing the pathology. And if we understand the underlying biology, then maybe we can target the underlying biology better. So in the last couple minutes, I just want to talk about new opportunities for pathologists. Why are pulmonologists less interested in having a pathologic opinion now in 2023 as we move into 2024? Why are the lung biopsies disappearing? Why do they send stuff off for molecular testing, bypassing a read by a pathologist entirely? And think about that as we are introspective about the things that we do. I think it's always helpful to think about, what value do I provide from what I do? And the reality is pathologists aren't providing enough value to the clinicians that the clinicians have any interest in knowing what we have to say. So can we change what we do to provide more value to the clinicians? And how do we do that? How can we increase the clinical value of pathology, where all of a sudden your pulmonologist wants to talk to you? Tell me what's going on in the lung. It's insufficient for me just to have a molecular genomics result. I want to know what you see and what you think the underlying cause of this problem is. Think about the power of the position that you're in and the potential for providing value to that clinician and the other people who are involved in that patient's care that cannot be provided in any other way. If you put yourself in that sort of light and realize the potential role you can play, I think it's really powerful. So I think there's a few things that we can do to increase the clinical value of pathology in lung specifically. First of all, we have a problem with standardization. The UIP that was originally proposed in 1969 by Averill Liebel, arguably the grandfather of pulmonary pathology, compared to the UIP that is codified in the 2022 consensus criteria, I should change this to say 2024 now, has really undergone a change and an evolution in how we think about what UIP is, the pattern or the pathology falling into that spectrum of findings, and it has narrowed considerably. If you go back to Liebo's original description of UIP as a pattern in the original paper, he describes all kinds of things, hyaline membranes, fibrosis. It's like every lung pathology that we can think of had been embroiled into this term, the usual interstitial pneumonia pattern. And now we have much stricter criteria. So we have gone from an era where all fibrotic lung disease was called UIP to an era where, with the current criteria, pathologists never call anything UIP. And then there are, of course, people who are sort of in between in various stages of this evolution. But that's a big problem for our clinicians. And we do have a standardization problem. So what can we do about that? First of all, we can improve guideline criteria. And I put a bunch of unanswered questions here that don't have to read this slide. This is just for your reference for later. But there are a lot of unanswered questions in our current diagnostic guidelines, our histopathologic criteria for fibrotic lung disease. Things like, how much lymphoid hyperplasia is too much lymphoid hyperplasia for UIP pattern? Where do you draw the line? We have no guidelines, no specific guidance on where we draw those lines and how we distinguish these things. How much bronchial eccentric change is allowable? What do we do when there's superimposed acute lung injury? What do you do when it looks like UIP but there's a bunch of organizing pneumonia that's also present? Current guidelines say that that's not UIP, or maybe it is if there's only a little bit. But again, where do you draw that line? How should the pathologist incorporate clinical history? Do you let clinical history influence how you sign out a case? If you know a patient has severe rheumatoid arthritis that's poorly controlled, should you change how you sign out that fibrotic lung biopsy? The current guidelines offer no guidance as to how or when a pathologist should incorporate clinical history into the evaluation or interpretation. We can improve these issues with some consensus, and there actually is some current push at the Pulmonary Pathology Society level to address some of these issues, to collect more data so that we can have data-driven, evidence-based improvements in our classification guidelines, but this is going to take some time. Number 3 here. I think we have an opportunity by developing a grade and stage system for ILD. Remember, the grade is the disease activity. Is it grade 1? Is it grade 4? Is it really raging active disease? Or is it mostly quiescent, mostly quiet, minimal inflammatory activity? Stage, the liver people know this well. Stage is important, right? What stage of fibrosis is there? We have no staging system for fibrotic lung disease. Why do we not have one? I'm not sure. It's certainly used in other organs. We have the Batts-Ludwig system for chronic hepatitis. We've got systems for non-alcoholic fatty liver disease. We've got scoring for lupus nephritis, IgA nephropathy, etc. So it's high time we had something similar for lung disease and started thinking about this, and this is something pathology can do. It's not something that the clinicians are going to do for us, but we have an opportunity to develop systems that will provide more value to the clinician from the biopsies that we see, where maybe they will be less inclined to just have it bypass us and our input and actually seek our input because this will be of value to them. Number 4, we have power now that we've never had before to have more of an individualized approach to pathologic medicine by combining things like molecular pathology and phenotypes with morphology. There's, the development of AI tools is often a hot topic. You can't talk these days about anything in pathology without talking about AI. The potential for AI tools and biomarkers to impact decisions through providing more diagnostic information, prognostic information, or therapeutic information is, we have this capability more than we ever have before, and it's actually already happening. This is just one study from a few years ago from a group in Finland looking at AI tools that quantify fibroblast foci in fibrotic lung disease and what that number of fibroblast foci per unit area, what the significance of that is in terms of patients' prognosis and inflammatory scores and how much inflammation is there and how it impacts prognosis. And there are significant differences. People who have lots of fibroblast focus activity, they do more poorly. More inflammation improves survival. To me, that's not surprising whatsoever. But rather than sort of a rough and dirty read of a pathology slide like we did in the past, we can actually be quite precise in our quantification of histologic parameters, and maybe that has meaning and value. And lastly, modalities are coming online that can minimize patient risk and maximize pathologic data. And this is something that Lita Hariri and colleagues over in Boston have been working on, this OCT technology. optical coherence tomography, where basically an ultrasound probe can be passed into the bronchus that can basically characterize the underlying lung structure such that biopsies can be targeted to specific areas where they might have a greater likelihood of providing diagnostic information, which is really a neat technology, I think, with these 3D reconstructions, as I'm showing here just from a recent review, and interfacing with these folks who are doing these more advanced techniques to make us better pathologists and decrease risk for patients. I think that's another opportunity for us. So that's what I wanted to share with you today. Hopefully that offers you some interesting perspective on where we are with ILD. I'm happy to answer any questions, and I promised Brooke that I would put this thing up for everybody to get their CME credits. I'll put it up there before I forget, but happy to entertain any questions either from the audience here or folks who are Zooming in. So thank you. I have one question in the chat. Oh, that's not a question. It's from Dr. Chen. Please enter your questions in the chat box. I agree with the suggestion. Yes?
So how about biomarker analysis? Is there potential to look for therapeutic targets and identify those within the biopsies or surgical?
Yeah, no, that's a great question. The question was, are there opportunities for biomarker discovery? I think that's something that is a huge opportunity. So think about how transformative it would be if a companion diagnostic were identified, the predicted response to anti-fibrotic therapy or predicted response to immunosuppression or some targeted therapy. That would be huge, particularly if it's a histology-based biomarker that can be evaluated in histologic context. I think that would be incredibly powerful, just like it has, these therapeutic biomarkers have transformed oncology. Imagine if we had the same thing in medical disease like medical lung pathology. It's a great comment. I can't wait to see what the field comes up with over the course of my career and how it might transform the practice of lung pathology, but also the care of patients with these problems. I wish I knew what they were, though.
Right.
Dr. Rashadi. Yeah.
So when you actually sign out these reports, I mean, I've seen some of your reports, obviously, but in the past we used to talk a lot about pattern. I think you sort of addressed a little bit here versus diagnosis versus etiology. When are you? I mean, I think we find ourselves in a situation where I think people know that like UIP is supposed to be a pattern, NSIP is a pattern of fibrosis, but it still gets conflated with being a diagnosis. And I think even in some of those guidelines, they talk about UIP, this is a UIP diagnosis. And I struggle still to wrap my head around that because I was taught so much that UIP is not a diagnosis, it's a pattern, and the diagnosis is more along the etiology, which can include IPAF, right? So how do you address that in your conferences and whatnot? Because I really separate those two things. There's a pattern, and then if there's other features present that suggest an etiology.
Yeah, I do exactly. This is a great question. So for those who didn't hear, how do I separate the underlying pattern from what I think is maybe the most likely etiology in terms of reporting? And I do exactly as you're saying that you do in your practice. I make it very clear in my reports that I'm referring to a pattern, and then I don't use UIP as the diagnosis. To me, the diagnosis is the clinical pathologic diagnosis after a multidisciplinary discussion. I put the word pattern after these things, so it's clearly understood. This is a UIP pattern. And in a comment, based on the fact that the patient is a 75-year-old man and former smoker with some GERD and no other obvious clinical findings to suggest an underlying etiology, this process would support a clinical pathologic diagnosis of IPF in an appropriate clinical setting, which is probably the most likely ultimate diagnosis in this patient if other causes have been adequately excluded. I might approach it like that, but I actually append the word pattern to all of these things to make it very clear what I mean. And I think that hopefully that helps.
Yeah.
And that's true not just of UIP. I'll call it an organizing pneumonia pattern, because organizing pneumonia is the same thing. It's just a pattern of acute lung injury and a subacute reparative phase. It's not a diagnosis, if you will. It's a pattern of injury, just like UIP, NSIP. These are all patterns of injury and the consequences of that injury in the lung, but it doesn't imply a specific etiology necessarily. It has to be combined with the rest of that information to come up with a clinical diagnosis.
So for the very first case you showed, how would you actually sign that out? Like, what's your top line?
That's a great, yeah, I should have come back to that case, thank you. So the very first case I shared that had sort of indeterminate histology based on current criteria, but the patient had a high ANA titer. She was a relatively youngish woman in her early 50s with hypothyroidism, and I think she had, even in the stem, she'd responded to steroids, I think, I forget. But to me, that kind of case really screams potential underlying rheumatic disease, connective tissue disorder. So on the bottom line, I would call that chronic fibrosing interstitial pneumonia, with features most suggestive of underlying systemic connective tissue disease. And in a comment, I might say, there's a fibrotic process. It's quite heterogeneous. It has features that are most consistent with a UIP-like pattern. However, there's also prominent lymphoid hyperplasia and these other features that suggest an alternative diagnosis to IPF. And in particular, connective tissue disease would be the leading consideration. And I dance around it that way. If I think it's a UIP pattern of connective tissue disease, I will state such, because I do think it has prognostic significance. An advanced fibrotic lung disease is always prognostically significant to recognize, but I do qualify it with what I think is the most likely underlying etiology based on the pathology, but also based on the clinical findings. So I don't sign any of them out in a vacuum. I always incorporate clinical and imaging information into my final interpretation of what I think the etiology is likely to be, which is sometimes easier said than done. And sometimes I can't be definitive. I have to sign it out descriptively.
Indeterminate pattern.
Yeah, and I think
features of UIP and NSIP, and often I worry about autoimmune disease.
Yeah, exactly right. I mean, I don't think you can be definitive in all cases. In some cases, don't have adequate clinical workup yet, so you have to be careful. The main thing there is to suggest what you think should happen next with the patient. Suggest that the patient see a rheumatologist. Suggest a more thorough search for antigen exposures. If it's really airway centered and maybe a little upper lobe predominant, I might favor HP. But every case is different, and it really comes down to the rest of the clinical and imaging findings as to how I might nuance any particular case. Yeah, any other questions online? I don't see anything in the chat. Feel free to chime in if anybody's calling in and has questions.
Auto wrap? We over time?
Well, thank you so much for your attention. Thank you again for the invitation. It's a pleasure to be here.